Hello everybody, welcome to my YouTube channel NurseEd Simplified. Today we will talk about one disease condition which was asked about by our students who want to know about the disease and finding it difficult to understand. So we will talk about multiple sclerosis. In this teaching, I will talk to you about what the disease is, its diagnosis, its pathology, its treatment, and finally the most important part, the care plan. So, what is very important to understand is what is multiple sclerosis. See, it is a chronic, often debilitating autoimmune disease that affects the central nervous system. So, our central nervous system, as you know, is composed of the brain and the spinal cord. So, what are the highlighting factors here? That it is a chronic disease, and the worst part is it is an autoimmune disease. So, what do you mean by autoimmune? That is, my body and its system and its immune system is against me. Just remember that part. That my immune system is against me. That is autoimmune. That affects which area? The central nervous system. Now, before we go into details, let's first know what are we talking about. I said about a word called myelin sheath, right? So we will talk about what is a myelin sheath. Now, when we learned anatomy physiology, we had learned that myelin sheath it's a fatty layer which basically covers your nerve fibers or your neuron, particularly which part of the neuron? The axon. Okay, if you can see the figure, you can understand. If I can show you here that this is your myelin sheath. This is your myelin sheath. Okay, this covers your, it is a protective covering of your axon. Okay, it is like an insulation to your axon. Okay, this whole part is your neuron, if you remember. Okay, now if you break it down, what is its position? It wraps around the axons of the nerve cells and produced by the oligodendrocytes. What are its function? Insulation, which means that it acts as an insulator. It preventing the electrical signal, that is your action potential, from leaking out of the axon. So the signal remains strong and focused. Next function, increase speed of transmission, which means that it allows the conduction to happen very smoothly as it should happen between the gaps in the myelin sheath, that is called the nodes of the Ranvier. Okay, this increase in speed, it travels down through the axon. Next is your efficient neural communication. And that is, a myelin sheath enables a nervous system to basically coordinate the complex body functions and responses efficiently. Next is protection, because it provides a protection. It is an insulation. It provides protection to the axon, protecting it from damage and everything. Now comes the term called, let me highlight it for you, what we are going to discuss, that is demyelination. This area, demyelination. So it is what? It is loss of destruction of myelin. This myelin sheath, it starts becoming less. And this protective sheath that surrounds the nerve fibers in the brain and spinal cord. So what happens? This whole function comes down. Insulation, speed of transmission comes down, neural communication comes down, protection comes down. Okay, and in the process, what happens is that this disturbs the transmission of the this function, transmission of nerve signals. Now, what do you mean by demyelination? As you can see in the picture, there is a normal axon where there is a myelin and there's a nerve fiber. What happens to a demyelination? As you can see, the myelin is disintegrated. So, okay, and there is disruption of the, so when the protective covering goes out from the axon, when the protective covering goes out from the axon also starts getting disrupted. So multiple sclerosis, it is a demyelinating disease in which the insulating covers of the nerve cells in the brain and the spinal cord, they are damaged. So this damage, it disturbs the ability of the parts of the nervous system to communicate, because the myelin is protecting the axon. That's why the communication is happening smoothly. So what if the protection goes out from you? So you cannot communicate that well. So what happens because of this communication? The basic function of the nervous system breaks down. So there are a lot of neurological signs and symptoms. Now, if you talk about the age, it is from 20 to 40 years of age. Women are more affected, and race, whites are more affected than the rest of the race. Now, etiology, we have risk factors. Under etiology, we have something called idiopathic. What do you mean by idiopathic? Idiopathic means something that it is unknown. Nobody knows actually a specific cause. Idiopathic is something like that. Immunogenetic viral disease, like if you have been exposed to Epstein-Barr virus. Epstein-Barr virus, okay, that has been out of studies. It has been found out that the virus, this exposure to this virus, is leading to if they have seen that once the patient has been exposed to this Epstein-Barr virus, it is leading to your exposure to multiple sclerosis. And a genetic predisposition, that is, if your genes, it is already running in your genes, you have this disease, you may be exposed. Again, this is etiology. What are your risk factors? Age, sex, family history, certain infections, as we said, climate, more in the cold climate, smoking, stress, fatigue, physical injury, pregnancy. Now we come to the pathophysiology. This is very important to understand. As we can see, due to some etiological factors, mostly idiopathic, means unknown. It's not that just because I have given you the etiological factors doesn't mean they are the ones responsible, but mostly unknown. They activate the T cells and the macrophages. What are T cells? They are our protective organisms, or rather, they are our immune system. Your T cells, your B cells. I will not go into details, but I will just give you some limbs up about what it is. So what are they? They are basically, they are types of lymphocytes. They are a type of white blood cell that plays very crucial role in the immune system. Just know this much, okay? So what happens because of the etiological factors? Your T cells and macrophages or B cells, they are activated, and they enter the brain from the peripheral circulation. Till here it's fine. Okay. Now, because of that, there is production of inflammatory cytokines by allowing the immune cells to bind to the receptors. The cytokines, they attract the macrophages and B cells as a part of the inflammatory response. The activated T cells and B cells, they cause the demyelination and destruction. Now, formation of plaques happen. This formation of plaques, they there are these are areas of scar tissue, that they are the ones that we see in the MRI scan, and we immediately identify that my God, this guy is a guy of multiple sclerosis. These plaques or these scar tissues, and the body tries to help. It starts the process of remyelination, but it is often incomplete and unsuccessful, and the immune system continues to attack the myelin sheath without knowing that it is my own body. As I said, autoimmune, which means my own immune system is against me. So the immune system continues to attack the myelin sheath. That leads to increase in the scars, and that leads to multiple sclerosis. Okay. Now we have basically three types. There are four, but we will discuss three main. Okay, that is most commonly seen. Number one is relapsing remitting multiple sclerosis. That is, there are periods of disease flares, that is relapses, and there are periods of remission. That is, there are good periods and there are bad periods. But there during this time, they also tend to disappear over months. Means after a long time, maybe you will see. Okay, so there are good periods and there are flare up periods, and the symptoms improve or disappear over years of months. This is the most commonly type seen. Type 2 is a secondary progressive multiple sclerosis, which means that it is a later stage, that it usually follows the relapsing remitting multiple sclerosis, that is type 1, where the disease progresses with a gradual worsening of the symptoms and accumulation of disability. So now from here the disability starts. Primary progressive multiple sclerosis, this is very rarely seen, where the symptoms gradually worsen without periods of remission, means mm, the onset and the disease flaring is very instant. It's very fast and there is no time gap basically. And but then fortunately this is very less common type seen. The most commonly type seen is a relapsing remitting multiple sclerosis. Clinical manifestation. There are many clinical manifestations related to your multiple sclerosis. Mainly they are dealing with your neurological symptoms, because as I told you that it basically affects your central nervous system. So first is your visual disturbances, optic neuritis, inflammation of the optic nerve, and it causes visual loss, blurred, double vision. Nystagmus, the patient comes to you with involuntary jerky eye movement, and because of that, he has dizziness and balance problems. And diplopia. The motor symptoms are your muscle weaknesses. Often your limbs are affected. There is difficulty with your walking, arm movement, fine motor skill. There is spasticity of your muscles, which can be painful. Ataxia, that is lack of coordination and balance problem, making it very difficult to walk, stand, or perform. And there are tremors. Very important for you to know, even when whether it is GNM, BSc, or whether it is MSc, the most important part I want to highlight is your Charcot's triage. Anyway, that you hear in the patient's file about Charcot's neurological triage is, okay, the Charcot's neurological triage of multiple sclerosis. Okay, it's not working. Anyway, Charcot's neurological triad of multiple sclerosis, you must understand it is multiple sclerosis. Okay, what are the Charcot's triad? It is nystagmus, dysarthria, that is, he's not able to tell you what exactly he's trying to say, and intention tremor, that is, there is some sort of tremor. So this together is called the Charcot's triage. So why I'm telling you about this particular disease, this about triad is because it generally comes in your multiple choice questions or something like that. So you will see nystagmus, as I told you, it is jerky movement of your eyes, involuntary. Dysarthria, it is a speech sound disorder basically, and you cannot articulate your words. Articulate means you cannot form your words. And there is something called intention tremor. So these three combining together is called forms your triad, Charcot's triad. So intention tremor is nothing, it is involuntary tremors, okay, of your limbs, maybe hands, maybe legs, whatever. Next is sensory symptoms. There is numbness, tingling in the limbs, face, trunk. There is pain and Lermit sign. This is also a very important sign. That is here, it is like an electric shock sensation that radiates down the spine. And sensory level, it is a distinct area on the body where sensation is reduced or absent. So if you heard two words in the file of a patient, one is your Charcot's triad positive and Lermit sign positive, you must understand the patient is experiencing or is being diagnosed with the disease of multiple sclerosis. Brainstem symptoms are your vertigo, dysarthria, swallowing problems. Cognitive is your memory problems. He cannot recall past events, or he cannot learn new information. Attention and concentration. He has difficulty focusing, staying on the task, processing information. And executive function, that is problems with your planning, organizing, problem solving. Okay. Next is a bladder bowel symptoms, that is your urgency frequency increases, incontinence increases, retention, constipation. These are your general symptoms: fatigue, extreme tiredness, and mood changes, depression, anxiety, sexual dysfunction, and other symptoms like hearing loss can be there if there is a damage to your auditory nerve. Next, we come to diagnostic. So, what do you mean by diagnostic? What are my tests that I will do to help understand the disease? Okay, so we will talk about it first from the medical history itself. You will be able to identify. That is the most important point. A neurologist will be able to easily identify the symptoms with the help of a medical history, physical examination, especially the ones done to do the balance, vision, and reflexes. He will confirm with the help of an MRI. MRI will help him determine the dissemination in the spaces, that is the lesions, the scars that I told you, and the dissemination in time, the DIS and the DIT. Okay, and the lumbar puncture is done to reveal the presence of, if you hear the word, there is presence of oligoclonal bands, which are proteins associated, which are released during multiple sclerosis. You must know that this is something related to your multiple sclerosis. Okay. Now, other ways are something that I have not written in the previous because but they are very new ways of identifying. So, how multiple sclerosis is diagnosed? Very simply, medical history, neurological examination, MRI, differential diagnosis. You rule out your meningitis and other symptoms, and lumbar puncture. You see oligoclonal bodies, you know that they are the ones. Okay. Next, we come to something called evoked potential. What are evoked potential? They are neurophysiological tests. What they measure? They measure the brain's response to stimuli such as visual, auditory, sensory input. Okay, they are very helpful in the case of multiple sclerosis, and they are used as biomarkers to see how the disease is progressing in the uh, whether it is relapsing and it is progressive or not. Okay. Next, we have something called we also have something called your McDonald's criteria. This is also a very new form of diagnosis. And with this also, we conclude that the patient has multiple sclerosis. So this is a criteria where basically the patient, it is a set of rules. So this basically helps the doctors. So here is like, it will tell you the clinical evidence, like if the doctor finds optic neuritis, the Charcot's triad, the MRI scan, that is if he is able to find out that there is a dissemination in space, the CSF fluid analysis, the diagnostic, like the McDonald criteria, it aims basically to take helps you to diagnose multiple sclerosis earlier so that we can start with the treatment earlier and the outcome is better. Okay, this is like a guide for them. Treatment. Now, as I always do, I divide it into pharmacological, non-pharmacological, surgical, and nursing. So, pharmacological is that we start with a disease-modifying therapy. That is what earlier we used to say steroid, 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 but now we have divided it into better ways to understand. So, first is a disease-modifying therapy, interferon beta. That is, you don't need to remember the names exactly, but if you see the names of medications like ocrelizumab and glatiramer acetate, you must know interferon beta. You must know they are for multiple sclerosis. Okay, so interferon beta, like you will hear names like Avonix. Glatiramer acetate, you will hear like Glatopa or Copaxone. Okay, and symptomatic treatments, what we do, we give for your particular diseases, like for muscle spasms we treat with baclofen. You will see patients coming to you with baclofen pump. Okay, so baclofen pump is given for patients mainly with multiple sclerosis to help them relieve the muscle spasm. We give them IV immunoglobulins. Okay, we give vitamin D so that they can come over some of the musculoskeletal system symptoms. Pain management, we help with antidepressants, muscle relaxants, anticonvulsants, corticosteroids, so that during acute relapses, IV methylprednisolone is the best choice of drug. Okay, and we also go for plasma exchange where the patient comes with severe steroid resistant attacks. This is the last resort, but this is also nowadays very commonly used. So the main is your interferon, DMTs, IV immunoglobulins, pain management, corticosteroid, plasma exchange. Okay. Now we come to non-pharmacological. Under non-pharmacological, we basically stress on multidisciplinary rehabilitation approach, which is physical therapy, cognitive behavioral therapy, and regular monitoring and follow-up. Next is surgical. Now, when we talk about surgical, what immediately comes to our mind is rhizotomy. What is this? This involves like a cutting or destroying of the nerve fibers so that it reduces your pain, your spasticity, especially in your head or face. How you do it, like it can be radio frequency ablation or with the help of some chemical injections. Now, intrathecal baclofen pump therapy, as I told you, for muscle spasm, they do have a process called intrathecal baclofen pump where it is instilled and the patient, it is released. The baclofen is released during intermittent intervals and the patient has some relief to the muscle spasm. Next, we come to deep brain stimulation. That is for severe tremors. What we have seen in the Charcot's triad. This DBS the DBS we also use in another disease that is called Parkinsonism. Very good. So Parkinsonism, it involves implanting electrodes in the brain. Connected, it will be connected to a device under your skin, and it interrupts your abnormal brain activity. Okay. So that is about the DBS. And sometimes you will also see patients with the feeding tube placed inside because they have swallowing problems also, no? Because if your brain stem is involved, as I told you, the sign and symptoms, you will have swallowing problems as well. Now, nursing management. When we talk about nursing management, our goal should be there, our intervention should be there, right? So in our goal, we have maintain optimal mobility as much as possible with the limitations and safety. Manage fatigue, maintain nutrition, elimination, hygiene, demonstrate coping strategies, participate in rehabilitation. Intervention, assess the neurological status, provide a safe environment, encourage rest periods, assist with the ambulation, promote fluid intake, high fiber diet to avoid the bladder bowel incontinence and constipation, provide a safe environment, rest with same thing. Okay. Next, we move on to the Nanda diagnosis. This is very, very important. So, we start with impaired physical mobility, obviously, because it is happening because of the neuromuscular impairment and the muscle weakness, as evidenced by unsteady gait and inability to move. Because patient will come to you with this problem: nystagmus or optic neuritis, ataxia, that is your gait problem, and your dysarthria, and decreased muscle strength. Next is fatigue related to disease process, impaired nerve conduction, muscle weakness as evidenced by patient reporting of exhaustion, decreased performance, and need for frequent rest. Self-care deficit because related to your muscle weakness and impaired coordination, fatigue as evidenced by inability to perform the ADLs, okay, activities of daily living. Risk for injury related to your sensory impairment, muscle weakness, visual disturbances, unsteady gait, as evidenced by use of appropriate risk factors, no defining characteristics since it's a risk diagnosis. But still, it is one of the very important diagnoses. That is why I have put it as 4. Disturbed sensory perception related to demyelination of the sensory pathways, related to unsteady, as evidenced by unsteady gait and decreased muscle strength. Next is impaired urinary elimination, urge urinary incontinence related to neurological dysfunction of bladder control, as evidenced by urgency, frequency, incontinence episodes, hesitancy. Bowel incontinence or constipation related to decreased mobility, as evidenced by involuntary passage of stool. Disturbed body image related to progressive physical disability, need for assistive devices, and social withdrawal. Ineffective coping because of this is a chronic illness and it is debilitating, which keeps coming and going. So there is an uncertain prognosis evidenced by anxiety, depression, and impaired verbal communication related to neuromuscular dysfunction and slurred speech. So in your 8 marks question, you must at least write 8. If it is a 10-mark question, you must at least write 9, and they should be the most important. As I told you, the most important priority diagnosis, then the intermediate priority, and then the low priority. Okay. So next we talk about rehabilitation. This is what you can see. Person in the center is a person living with the multiple sclerosis, and we can see our role: maintenance of psychosocial well-being. You nurture relationship, help introduce them to support systems, spiritual, emotional aspects of life, peer support groups. Preventive visits are done by the primary care provider. We visit annually for prevention, schedule additional visits to manage risk, and self-empowered choices, that is up to the patient. Learn the invisible symptoms, maintain nutrition, diet, incorporate exercise, mindful movements, and of course, quit smoking and limit sugary foods. Thank you so much. As you can see in this, we help as a team by the patient, family, as well as by the us as a nurse. We help them overcome the limitations because of multiple sclerosis. We do not stop the disease or the progress of the disease, but you help them overcome and live with it. So thank you so much. Do not forget to subscribe and like my channel. Thank you. Bye bye.